Please welcome to the stage President of the Kate B. Reynolds Charitable Trust, Laura Gerald.
Good evening, good evening. How are you all enjoying the first day of the conference so far? Awesome. We are truly having a great day. It is indeed my pleasure to welcome you to the Grant Makers in Health Plenary session on advancing equitable quality care for people with serious illness. I am Laura Gerald, President of the Kate B. Reynolds Charitable Trust and Vice Chair of the GIH Board of Trustees, and it's my pleasure to introduce our panelists for the session. We have 4 distinguished speakers whose full bios can be found in your program materials. Our session moderator is Dr. Cardinal Carty Smith, an oncologist and palliative care physician and professor in the Division of Hematology and Medical Oncology at the Icahn School of Medicine at Mount Sinai. She also serves as the Chief Quality Officer for Cancer Services in the Mount Sinai Health System and is a health disparities researcher. She's joined on the panel by Dr. Nick Dion Odom. He is a nurse and assistant professor in the School of Nursing at the University of Alabama at Birmingham, and founding co-director of Caregiver and Bereavement Support Services in the UAB Center for Palliative and Supportive Care. Our next panelist is Dr. Maraset Hassan. She started her career in nursing and is a registered nurse, and is now the president and CEO of the Carolina Centers for Hospice and End-of-Life Care. Dr. Kalia Johnson rounds out our panel. She is the Division Chief for Pediatric Palliative Care at Children's Healthcare of Atlanta and Emory University's Department of Pediatrics. She also works clinically at Grady Medical Center, and I've also learned she is a former Johns Hopkins Pediatrics Residency Medicine specialist, a fellow Harriet Lehner. All of our panelists are deeply committed to chronic illness and palliative care and health equity, and are sure to engage in an informative and riveting discussion. Please join me in welcoming our speakers.
Well, thank you all for being here at the end of your day. I realize that we are what's standing between you and the fabulous reception, so hopefully we can keep it entertaining for you. The title for this panel is Advancing Equitable Quality Care for People with Serious Illness. And I thought we'd start with just laying the groundwork for some of the definitions. So what is serious illness? You know, serious illness is an illness that is associated with high level of mortality, of death, and often is associated with impairing someone's quality of life or their functioning, or seriously impacts their caregivers. And palliative care is medical care that aims to relieve the suffering and symptoms associated with the serious illness, like pain or other symptoms, for patients as well as their caregivers. And it's given by an interdisciplinary team of physicians, nurses, social workers, chaplains, and other integrative care support services. Palliative care is different from hospice. Hospice is really something that is given when someone is more towards the end of life, and hospice is a Medicare benefit. So the definition is that someone has to have a life expectancy of 6 months or less to qualify for hospice, and they're not able to receive life-prolonging treatment, or in the case of cancer, for example, cancer-directed treatment at the same time. So, those are the definitions. Sorry to bore you. And, you know, thinking about the definitions of serious illness, you know, Kalia, can you tell us why serious illness? Why is that important?
It's a great question. Thanks, Cardi. So in thinking about this question, I thought it would be poignant to share a patient story. There's a patient of mine who I have cared for now for several years. She's a 19-year-old young woman. We'll call her NT. She is African American, was born in South Georgia, so pretty rural corner of our state, and was born with sickle cell disease. She struggled throughout childhood into early adolescence with complex pain related to her sickle cell disease. and ultimately went on for a bone marrow transplant to try to cure her. She developed lots of complications from bone marrow transplant, so it was essentially trading one chronic disease for another. And through this was still an emerging adolescent into now young woman. Very sadly, just shy of a year ago, she was concomitantly diagnosed with HIV. So here we have it, a young woman who has lived with serious illness throughout her life. Though she has survived, the quality of her life has been impaired, not just because of her serious illness, but frankly because of social determinants of health that have affected her ability to access care. And palliative care has been a key aspect in her life that's helped to support her well-being. We've been able to provide her with palliative care across a continuum from cancer, bone marrow transplant therapy and treatment through to her HIV care. And it essentially is a lifeline for her to help her figure out, how do I live well with these frankly serious life-threatening illnesses? And I think she is a snapshot of some of what we're seeing in pediatrics in general and throughout healthcare. We're getting better and better at pushing the envelope with technology and therapies to keep patients alive. But within that, what does that mean? How do you live well through all of this? And when you layer in this added dynamic of inequities in healthcare, how can we be present for patients through that? And I think palliative care is one example of a care model for how we can do that.
Marissette, you want to tell us why serious illness?
Yes, and thank you. It's good to be with you guys today, and I see you're celebrating 40 years, so kudos for that. And I also want to share that this year is 40 years for the Medicare hospice benefit from the launch, and so look at that, 40-40. And so for me, when we think about serious illness care, I think about the fact that 40 years ago, there were gaps in care, that there were people dying and having extreme pain. There were folks that did not have support of someone coming into their home or having a place to go, and Connecticut Hospice was born. And so I think that is why serious illness care, when we look at the continuum from palliative care to hospice, that it's important for us to bridge those gaps. It is important for us to reduce suffering at the end of life, and it is important for us to give people hope. So that's why I feel that serious illness care is important.
Great. And Nick, you know, Kalia's mentioned she mentioned already equity, right? And when we think about serious illness care and equity, I think there are lots of things that one can talk about and how they go together. But before we do that, can you help us define what health equity is?
Sure. So one often thinks of equality and we think of equity, and these are two different constructs when we think about health equity. Equality is everything getting the same resource in the same amount of the same type of the same kind. You might also think of this as fairness. And often what this does is it overlooks that we all often start at different places. Equity is actually looking at the outcomes of whatever it is we're talking about. So in this case, serious illness outcomes or health outcomes. And equity is the sense that we should titrate what we think of as fair based on equity outcomes, such as what everyone's health is looking like when they're living with a serious illness, like perhaps their quality of life. So when we're thinking about equity, we're thinking about how to evaluate what we take to be good health care in terms of how everyone is turning out, not just in terms of what everyone is getting. What everyone is getting should be based on how everyone is turning out. Yeah. So that's what we think of when we think of health equity.
Yeah. And for you, why is that important in palliative care?
It's important in palliative care because it's been noted that there's a lot of disparities in how people live with serious illness in this country and how people die with serious illness in this country. For example, people of color are more likely to receive aggressive interventions at the end of life. They're more likely to not use hospice. They're less likely to have an advance directive. They're more likely to die in pain. So we know there are disparities in serious illness care. And so this is where the two, for me, intersect and what needs to be a priority, I think, when we're talking about where do we go next with palliative and serious illness care.
Yeah, okay. Thank you. Marcette, I'm wondering, what are your thoughts about that? How do those things intersect?
You know, so often when I think about some of the barriers that are there, I think a lot about the need for us to really be able to engage as clinicians across the spectrum, regardless of what I may look like or what my patient may look like. And sometimes I feel like those disparities happen because we don't understand each other. And because when we look at the fact of a lot of the illnesses that are out there that have, you know, high morbidities, we look at it in communities of color. And so we have to kind of get to the bottom of those kinds of things. And so when someone shows up, you know, at the hospital, recently I had an experience with my husband. He was diagnosed with COVID back in August, and thankfully he was able to get through that, so we're really grateful for that. But those first few days of trying to find care and to go to an emergency room, 2 different emergency rooms, one experience where he came in and he was so sick and I knew that he had COVID, but he wasn't triaged right away. He was pat down by the security guard to make sure he didn't have a weapon. He had to wait for 5 hours and never got seen. And so the next day we went home, and the next day we went to another ER, a public ER as well, but the treatment was so different. There was respect. There was someone explaining the process. There was saying, hey, let us get him back. He's having a hard time breathing. We need to get him oxygen. And so he wasn't judged as this, you know, African-American man that's just stumbling in as if maybe he was a drunk. So, and so I think those are the things, we have some implicit biases that sometimes we judge people by. And for me, it's important for us to educate so that we don't have that happen to people.
Yeah. You know, this implicit bias piece that you bring up, I think is definitely important and interesting. You know, there's work showing that, for example, work that I've done, that I've participated in, showing that oncologists, when having conversations with their patients with cancer who are coming in for scans after being on cancer-directed treatment, right? So scans either show that the cancer is getting worse or it's not, but it's an opportunity to have a conversation. And in those settings, oncologists spent 3 minutes less talking with their minority patients, their Black and Hispanic patients, when compared to their white patients. And so, you know, what's happening in those clinical encounters that's impacting the care that we are advising or the care that's being received.
Yeah. I think earlier we were chatting together about how our interactions are more transactional than they are engaging in a relational, trying to build an authentic, trusting relationship, because we've got a bill and so we only have so much time, and so we're trying to get through it instead of really trying to garner that trust through those interactions. So.
And Kalia, as being in the pediatric space, I imagine this looks somewhat different for you, but yet maybe the same. You want to talk about what that equity in serious illness care and palliative care, what that looks like, that relationship?
Sure, absolutely. I think the immediate thing that comes to my mind is the reality that we see in this country as far as poverty goes and how that impacts children. So children are the age group of folks most affected in this country by poverty, and that in turn means they are most impacted by other social determinants of health that relate to poverty. Food insecurity, homelessness, inadequate access to education, you name it, those things disproportionately affect children. And we know that inherently by their nature, children are more vulnerable. They can't always speak up for themselves. They rely on adults to advocate for them and speak to their challenges and their needs. So certainly within serious illness, we think about all of those factors and how they are layering in on top of the reality of complex disease. I certainly see that front and center in my setting in Georgia, where at our hospital, Children's Healthcare of Atlanta, 40 to 50% of all of our pediatric patients are qualifying for Medicaid or receive Medicaid. We are largely a rural state because we are the pediatric health center for the state of Georgia for all intents and purposes. We pull from all over the state. So we see a lot of these realities of what it means to live in circumstance of inequity and how that affects serious illness.
Yeah, yeah. And I think there's certainly lots of evidence and data that shows that when palliative care is integrated alongside routine medical care, whether that be cancer care or other care, that patients have an improved quality of life, right? They have improved mood. Their caregivers have improved health, and also improved survival as well when receiving palliative care. And yet, we know, unfortunately, that many people don't have access to getting this care that is so critical. And so, Marisette, when you think about some of the structural and institutional barriers that exist to receipt or increasing palliative care, could you share with us some of what that might be?
I think a lot of times I think about health illiteracy. And oftentimes, the clinician's going to come in and going to explain what's going on, but the patient may not be at the same level because of their educational, background. And so we tend to sometimes explain those things, at a higher level than what the patient can understand. And so then you've got a divide there where the patient is not sure about what they can expect. And I think also we've been doing some work with CAPC and also with Ariadne Labs around the need of really talking about race and how we enter race dialogue into those interactions. How do we prepare our clinicians for being able to have those interactions? And I think that's one of the things that we don't see a lot of. We're not trained, Right now, a lot of our young people that are coming out, I'll talk about my young people, you may have some young adults in your house that all they do is text. I mean, they could be upstairs and they're not going to have a conversation with you. They're going to text it to you, right? And so we're not used to, in this generation, of engaging in a conversation and asking a person about their story and finding out from them what matters and what happened so that we can then put together that plan. And so I think that's one of those barriers that we definitely have to help our clinicians that are coming out to help them be able to do that. So.
Yeah. Thank you. I think that's a really, really wonderful point. And Nick, I'm wondering, what are you thinking are some of these barriers that exist?
I can think of a lot of them. I think one that, very concrete, there's really a lack of a quality standard that's specifically focused on health equity. So all healthcare systems have quality metrics that they need to meet in order to negotiate with insurance and payers in order to get reimbursed. There doesn't currently exist a metric that's specifically focused on health equity. And what that does is the system will structure itself to whatever the incentives are. And so in this case, without a metric that's focused on health equity, the system itself won't conform to that. And if they do, it's typically a place or a center that's affluent or has a lot of resources, and they can do that sort of thing. But it won't create system-wide change where you can see it on a broad scale. So I think the lack of that sort of quality metric and the lack of a payment system that's overlaid on top of that really disincentivizes a system from structuring itself around health equity.
Yeah. And sometimes the measures that we have actually do the opposite, right? They create disparities. I think about, as an oncologist, my world is cancer and palliative care. And I think about this metric of good quality being receipt of hospice greater than 3 days before death, right? And yeah. And I think, hospice is wonderful, and yet it is, one, not what everyone wants.
Exactly.
It is, two, not how everybody wants to die, and three, it's just not attainable for many. Hospice as a construct requires you to die at home. There are many communities in this country whereby they don't have the support or the resources to be able to do that. Add that there may be cultural factors or beliefs,
Absolutely.
right, that aid in that. And so, I think also when we think about how we put these measures in place, thinking about what some of those unintended consequences may be is important. And Kalia, I'm wondering, what are you seeing from your vantage point in terms of some of these barriers that exist to getting to equitable palliative care?
I really appreciate what both of my co-panelists have just said, and particularly Marisette, thinking about strong constructs like racism. How do we really start interrogating the impact of structural racism in the healthcare space intentionally? But immediately my mind goes to silos. I think our healthcare system in the United States is inherently very siloed, and you can look at those silos from different angles. As a pediatrician, I look at it from the angle of how we silo care around age groups, right? So we traditionally have very little crosstalk between what happens in the pediatric clinical space and what happens in the adult care clinical space. But again, as we're looking towards the future and we're looking towards the scene, how do we break down those silos so we can have better crosstalk between different points of the continuum, so we're learning from each other and elevating one another? I can think about the COVID pandemic as an example, a pretty concrete example. How long did it take for us to get the vaccine for kids? Right? We've just this week, and I know many of the clinician scientists who were up in the lab across the street from where I work in my office, working 24/7 at some point, honestly, to run these clinical trials to get vaccine access for kids. And here we are 2+ years into the pandemic, and we're just getting it for kids. Why is that? What happened with the adult trials that pushed further and first, where we didn't have that phenomenon in pediatrics? So thinking across age groups with the silos, but also too how we can often put types of care into boxes. So we talk about this model of concurrent care, which is a provision under the Affordable Care Act, which essentially has created a federal law that says underneath Medicaid services, individuals who have serious illness are afforded the right, if they are 21 years of age or less, to access hospice services concurrently with treatment-directed therapies. So it's from this mindset and philosophy, as Cardi has been referencing, that palliative care is just good care, hospice care is good care when you have a serious illness. How do we layer in that support regardless of where you are in the treatment path, treatment algorithm? We've done concurrent care now on the pediatric side for over a decade, almost 12 years. And there's been some Medicare demonstrations on the adult side that have just started showing the benefit. But the silo has really been in prior to concurrent care, there was no ability to access hospice in addition to treatment-directed therapy. So how do we break out of these boxes to start doing what just is the right thing for patients and families with serious illness?
Yeah. And I'm curious, Marisette, if you were going to please go ahead.
I was actually thinking about what you shared earlier about having oncology patients and they're not wanting to have hospice. I can remember years ago when my mother was ill with stage 4 colon cancer, and we went through treatment and we were all gung-ho, and of course for 2 years we beat it, right? And then at the end, we had to, think about hospice. I was a new nurse, wasn't ready to have that conversation, wanted mom to do more. And so it would have been great had there been that option for her to be able to get the supportive care as well as the hospice care, and to get that before the month before she died. And so at some point the oncologist probably knew that's where we were, but because I wasn't ready, I was a new hospice nurse, 29, I'm like, I'm not ready for my mother to leave yet. This is not in the plan. I need her here a little bit longer, right? There's still younger kids at home. But we didn't have that as an option. And for some families, the option of hospice seems like it's a barrier to care. and that I'm going to be made to give that up because my faith tells me that there's going to be more. There's going to be that miracle. I need to push for more. But if you put me on hospice, then that means that essentially you're telling me that I need to give up. And that's not always what someone wants to hear. And so if we had that option of concurrent care for adults and could see that we could keep people out of the hospital and we could start sooner with care, and then by the time we get to where we need it, then we have greater acceptance because we're not jerking somebody, you know, into making that decision when they're not ready for it. So, and likewise, oncologists are trying to keep people going, you know, and to give them that hope for another day, you know. And so I think there has to be a blend between the two, that we should be able to do that. And obviously we've worked it out for the children. Why can't we do the same for adults?
Yeah. And just sticking on that same thing, Marisette, and thinking about hospice and why some communities of color may not be accepting of it. You know, we often talk about trust as playing a big theme. Can you talk about that a little bit?
Yes. You know, when you think about the Tuskegee situation, and most African Americans have heard about the treatment that was done, you know, with those particular patients. And so when you talk about taking something away, it looks like I'm not going to get the quality care that I deserve. And so once again, I'm being discriminated against. And so I'm trying to foster trust. And so I'm not able to get that when it looks like you're taking, you know, things away from me. And I think the other thing that sometimes play into it is sometimes the caregivers who are coming to talk to me don't look like me. And so there again, I have to get over that barrier that there's not a lot of African American clinicians, you know, like the ones we see here today, who are providing this care. And so sometimes it's easier to make that transition when the person that's bringing the message looks like you and is trained. Now the reverse can happen. I've heard that as well. But many times our workforce is not diverse. And so that's a concern as well. How do we get more qualified clinicians of color who can help us in those communities and in some instances speak that language, make that bridge, you know, so.
Yeah, representation matters. I know my daughter is planning to be the next president because of Vice President Kamala Harris, right?
Yes.
Yeah, it matters. It matters.
It does.
And I think to your point, only about 5% of all physicians, right, identify as a person of color, and we compare that to about 25% of the U.S. population. So there's a disparity there.
Absolutely.
You know, Nick, I think Kalia and Marisette both referenced COVID as they were speaking, and you know, it is all around us. It will never go away. I'm wondering what role or what impact do you think COVID has had on some of these barriers that we're seeing, some of these inequities?
So to say a little is almost to say a lot. So COVID has peeled back, I think, structural issues that have always been there, and they've simply exacerbated them to an exponential degree. And a lot of these have to do with what we often discuss as social determinants of health. So Leah earlier was talking about things like early childhood education and food insecurity and access to primary care. A lot of these structures existing really outside of the healthcare sphere. And those parts of the population that tend to face more challenges with these social determinants of health are disproportionately people of color, folks who are poor, folks who live in rural areas. And when COVID hit, it simply magnified these already existing social determinants of health, which is why, you know, people of color, you know, folks who are poor, they're not more susceptible to COVID. There's nothing physiologically about them that makes them sicker, and yet they experience disproportionate mortality rates because of COVID. And that's because of what was already pre-existing, which is, you know, a vast majority were frontline workers. They're working in jobs where they don't have full health insurance, they don't have paid family leave. a lot of these issues just magnify the disparities that honestly were structural issues that had always been there.
Mm-hmm. Yeah. Yes, and now we have to dig ourselves out of that. And so, you know, there are 45 million people in this country, approximately, living with serious illness. We know that there's a treatment, there's medical care, palliative care, that can be helpful to help them have good quality of life and live with their serious illness. And we have the fortune of sitting on the panel in a room full of grant makers. So, you know, I'm wondering, Nick, if you maybe would start us off on, you know, what are some of the most important strategies or areas for philanthropic investment?
I'd like to just paint a little context here for everyone so that, and I may be telling you all things you already know. The National Institutes of Health is the major funder of health research in this country, and their budget is about $45 billion. That might sound like a lot. The budget of the DoD is about $1.5 trillion, so just to put some context. That $45 billion, of that $45 billion, about 0.2% is spent on research that's focused on serious illness care. This is a work that Laura Gelfman, a colleague of ours, has been doing now for the past decade, looking at the proportion of grant funding that's gone towards serious illness research. So there's a very small proportion of NIH funding that actually goes towards research that's focused on palliative care. So the first big takeaway I'd like to send to you all is that if you think that we're getting adequate research funding from the federal government, we're not. If we're thinking that a population of 45 million, and I haven't even brought up my soapbox of family caregivers yet, which is another 55 million, many of you may in this room be a family caregiver to someone with serious illness. But we don't have a lot of funding there, and it would be great if philanthropic support could help us fill in some of these gaps. And I'd actually like to expand on specific gaps, and so that's part of the context. Here's some other parts of the context. Some of the organizations that have philanthropically funded palliative care research that's not NIH are sunsetting. One is the National Palliative Care Research Center. It's philanthropically funded and will sunset in 2 years in 2025. That organization has funded career development awards that has launched early career investigators to get large grants that we call R grants. It's just very large grants that allow us to do research that has high impact. The Palliative Care Research Cooperative Group is another entity that has often funded palliative care research. It is also sunsetting in the next year because of lack of funding. The National Institute of Nursing Research is the major institute within the National Institutes of Health that has funded serious illness research, and they have now shifted their priorities towards other priority areas and has shifted its focus away from serious illness research. And the Cambia Health Foundation, 3 of which of us are funded by, has a leadership program that helps fund 2-year grants to help stimulate palliative care research and leadership development. That funding is also sunsetting in the next couple of years. So we're sort of at a point where a lot of the support that we have been receiving over the past couple of years is going away. So I would please ask all of you to think about ways that you could include research funding as part of your portfolio of funding, is what I would ask you. And I'm happy to talk to anyone. Over drinks is where you can influence the most people, I think. So I'm happy to talk with anyone further about what that might look like, but any help that we could get with trying to stimulate particularly early career researchers and getting early funding to be competitive for these large NIH grants would be one of the things that I would hope that you would all take away from today, is something you could really do.
Thank you. That really set the stage for how bad things are going to look in the future.
It's an opportunity, though, right?
Yes, Melissa, tell us about some other strategies that you could think of.
You know, when I think of other strategies, I am really concerned about our nation in terms of the amount of grief that we have experienced over the last 2 years. More than 1 million people have died in our communities nationwide, and there are communities that are not whole, that we need to really put forth some things in terms of looking at how we can provide bereavement counseling. You know, hospice, the hospice benefit for those who are in that category, provides 13 months of bereavement care, but there are whole communities who don't qualify for that. And that happens in those particular situations where patients have died on hospice, their caregivers get that follow-up. But when you talk about death from a pandemic, where several people in a family died, several people in a community died, I believe we were chatting earlier that when one person dies from COVID, 9 people are bereaved. And so when you think about 1 million, there's 9 million bereaved. When you think about 1 million people who've died, there are 9 million individuals who are bereaved across our nation. We really need to look at what can we do to provide that kind of education and support, because when people are bereaved at whatever level, things change for them emotionally, but it also can change for them physically. Caregivers are impacted about what they can continue to do because of that grief. We've had young and old to die. So I think that's one area that we can look at. And the other is really looking at how we engage in partnerships with health systems to really bring whole communities together. And that's another thing that can help us with our silos.
Yeah. And just because we were talking about this a little bit earlier, but particularly when we think about community partnerships in communities of color, you know, you talked a little bit about faith-based organizations.
Yes.
You want to say a little bit about that as a potential area or strategy?
Yeah, I think a lot of times we forget about how the faith community has influence across our nation, particularly in communities of color. We see where the church historically has been a huge factor. And so I think we have missed an opportunity sometimes to engage in having those kinds of partnerships. Over the last 3 or 4 years, I've had the opportunity to do some work with the Harmon Foundation, and CTAC has done some work as well with faith communities and looking at advanced care planning. And I've seen that when people receive the knowledge, they're eager to take that back. And to help their people to see the benefits of starting advanced care planning early. And so I do believe in lots of communities, there are whole denominations of faith communities that are doing health initiatives. I know, for example, with the African Methodist Episcopal Church, they have taken on diabetes and have done some work with that. So I do believe that that's another avenue for us to look at, bringing in those partnerships where health systems, post-acute partners, and faith community members can come together to make that community change.
Yeah, absolutely. Thank you. And Kalia, what are you thinking are some strategies or areas for philanthropic investment?
I definitely will share my perspective as a pediatrician that we need to seize whatever opportunities we can within the serious illness space and beyond to fund research, programming, advocacy work that is focused on children. Certainly as a palliative care specialist and expert, I can say pediatric research and programming for children who need palliative care and who have serious illness is underfunded. And there's a huge opportunity there. I think particularly it's important for us to look at transitions in care. Again, going back to this concept that I brought up of us pushing the envelope, people living longer. Certainly children, young people are living longer with serious illness, and our goal with children, young people in general, should always be around promoting their well-being, promoting their ability to thrive regardless of their situation and circumstance. So as we look towards launching these young people with serious illness into adulthood, how do we really facilitate those transitions well? How do we work again across pediatrics to adult? Leveraging the support of palliative care programming to ensure that young people can live the best lives possible for as long as possible. So those are the immediate thoughts that come to my mind.
Right. These are all really, I think, tangible things that we can do. And just sticking with that, because before we move on, Nick, you had mentioned something earlier around workforce. And I didn't know if you wanted to mention something about that, about how that could be an area of strategy for investment outside of career development for researchers.
So Arif Kamal, who was at Duke, is now the Chief Medical Officer of the American Cancer Society, had done a lot of work on the palliative care workforce. And it's a relatively small subspecialty workforce, and I'm including here physicians, nurses, social workers, palliative care chaplains, social workers, et cetera. All of which you can get board certification to be in palliative care and this be your day job. That workforce is predicted to increase about 1% over the coming 20 years. However, the serious illness population is expected to increase by about 20%, which is to say that the number of folks, and this is currently already the case, that could use the support and assistance of specialty palliative care already proportionally far exceeds what our workforce capacity is, and it's probably not going to get better, and it's probably actually going to get a little worse. So what does that mean? I think that means some points brought up earlier about using some untapped workforces like community health workers, lay patient navigators, et cetera, a lot of community resources to help bolster some of the support in sort of a stepped care model. So
it sounds like you're saying that we need support so that when my mom needs serious illness care, palliative care, or maybe even me, or some of us on this panel, that will, and in the audience, that it will be there when we need it. Yeah. And so thank you all for these really great examples. When I think about some of the impact that funders have had in this space, I think there are several examples. You mentioned Arif Kamal. He actually was a scholar, a Cambria scholar, like Kalia, Nick, and I. And I also think about CAPC, the Center to Advance Palliative Care, which was founded by Dr. Diane Meyer at Mount Sinai and started from support from the Robert Wood Johnson Foundation and continues to get support from other groups to this day, other foundations. And the Center to Advance Palliative Care, right, really it's a hub for all of us to learn about models of palliative care delivery and how to make the business case to our healthcare systems or institutions, and really gives us that roadmap. Are there other examples that you can think of?
Just to piggyback, Cardi, on your mention of Diane Meyer, she started as a Project on Death in America scholar, which was funded by the Soros Foundation, which ran for a similar frame of time as Cambia's Sojourn's leadership program has run. So I think it sets a good precedent that ideally we have another foundation, particularly given the evidence that Nick is giving us with the statistics of how serious illness is growing. We can share it anecdotally, but to have the statistics, it's so powerful. There needs to ideally be another foundation that is going to come and pick up the funding of innovation in palliative care. How can we think out of the box again and really push pre-existing constructs, break down the structures, so that we ensure that everyone in the population who needs this kind of care ideally can receive it?
Yeah, it's another great example.
Yeah.
Marisette, can you think of?
Yeah, there are a couple things that come to mind. I'm from the Carolinas, so in North Carolina, back in the early 70s, we did not have hospice, and there was the North Carolina Community Foundation that did a seed of $200,000 to start 15 hospice programs. And today we have hospice that is across, there are 101 counties in North Carolina. And because of that philanthropic effort, as well as we also, as the Carolina Center, received donations from the Robert Wood Johnson to really work on advanced pain management and to really teach clinicians how to provide pain management for patients throughout the serious illness care continuum. So that those donations were critical in terms of helping the field know how to do what they were doing during that time. Most recently, been doing some work with Dr. Kimberly Johnson, who received a large PCARI grant about 4.5 years ago to really look at testing a couple of evidence-based models on teaching African Americans, finding out from them what's the best tool to use for advanced care planning, contrasting respecting choices from 5 wishes over 5 states. And this is where we're recruiting 800 patients, 400 African American and 400 white. We are in year 4.5 of that because the pandemic hit, so we will be wrapping this up towards the end of the year. But some amazing work being done using community health workers to actually engage with patients. They've been trained, and it's just been phenomenal to see the advance with those. So I think that that's really good. And lastly, I would say that we really need to look at how can we take nursing schools to work with CNAs to put them on a track to increase the pool of nurses. We know we've got workforce shortage. Is there a way that we can begin to pair those groups up and to expand the nursing workforce? We've had lots of nurses leave the workforce during the pandemic and retire, and we don't have the replacement with those that are in school now. So we've got to have to come up with a creative way to do that. So.
Sounds like one of those innovative out-of-the-box.
Absolutely.
Marissa, I'm just thinking maybe we should circle back to defining advanced care planning. It's kind of like palliative care. I don't think necessarily everyone knows what that is and why it's so important in serious illness.
Yeah, so when you think about advanced care planning, in short, it's the process of having conversations ahead of time of what you would want done if you could no longer speak for yourself and tell others what you would want at the end. I dare say in this room, by a show of hands, how many of you have had a conversation with your family about what you would want if you could not speak for yourself? Can I see those hands? So that's a good, give yourselves a hand on that. That's great, because that's a tough conversation sometimes. Half the room didn't raise their hands because it is a tough conversation, right? And so conversations need to happen first before you go to a document, an advance directive, something like a living will or a healthcare power of attorney. And so it's important for us. I know there's controversy out there about that, but we know that if people can begin to have conversations before they're in medical crisis, then it allows them to make the best decisions when that crisis occurs.
I interviewed a chaplain once about advanced care planning. He gave the best answer. He said, I do advanced care planning every single Sunday when I go to church. Is that not planning?
Absolutely, Nick.
For your life's end? So,
yeah. Write the vision and make it plain.
Some people think about it as the piece of paper that you fill out. And I think that we can get a little bit broader minded there when we think about what do we mean when we talk about advanced care planning and what matters to us in life.
Yes.
That's right. Any examples you want to give about some success stories in funding, philanthropic funding?
Well, I'll just get back in my research box here. Peggy McGuire, who runs the Cambia Health Foundation, leads the Cambia Health Foundation, recently presented us with statistics about the return on investment for every dollar spent by Cambia on its Cambia scholars. There's been somewhere around 100, I believe, and these grants are 2-year grants. They're $90,000 per year to support salary and a project and some leadership development. For every dollar spent, there was a $10 return on scholars being able to acquire future grants. And so it's a 10-to-1 return for every dollar spent. So I think that just in terms of a good return on investment, don't check your 401k today because that's too low of a bar. But this is a really good return in terms of investing in the research infrastructure of serious illness care so that we can build the evidence base that demonstrates not only better care for people, but in a way that's sustainable and scalable and in a way that we can actually, pay for it and make it work for everybody.
Yeah, great point. Thank you. And now I'd like to open it up and to give the audience some time to ask any questions you might have. I believe there is a mic, or you can,
Yeah,
See some
we don't have any
heading
on
over
the-
to the
on
microphone.
the virtual ones. We're almost out of time.
Thank you very much. This is a really important topic, and I've really enjoyed your presentation. I just had a quick question. My name is Donna Sullivan. I'm here with the Alliance Health Foundation, but my backstory is as actually a rare disease mom and an advocate for chronic and complex pain patients. I do a lot of work with sickle cell. And when you were talking about funding opportunities, at this conference, we're looking a lot at issues of health equity. And we talk a lot about what happens when a patient has problems accessing the health care they need. From a funding standpoint, have you seen anything, or what are your thoughts on what happens to complex patients or seriously ill that can't access their care from a psychological standpoint? In particular, I'm talking about like PTSD, maybe from not being able to access in medical settings. Are you seeing that? Are you seeing initiatives or funding going towards that problem? Because I can tell you that it seems to be a growing problem, and it's something that now I think the world is starting to understand better, because a large percentage of people with COVID that have had trouble accessing care did experience psychological trauma, because of that experience. So I guess that's my question. Is anyone looking at that? Is anyone funding it? Do you have any thoughts on it? Thank you.
No, Nick, you do.
Yeah, so a lot of the way NIH works, they have what's called funding opportunity announcements. It's sort of like instructions for writing a grant, and they will often have stipulations in there for what they would like to see in those grants. And a very good trend that we've seen for these NIH institutes is a lot of desire to see applications focused on health equity, health disparities, and bolstering research in this area. The National Institute of Nursing Research in particular has taken a very strong shift towards a research portfolio that is specifically focused on health equity research. So I'd say that the one program that that's quickly coming to mind, RWJF, has a program that's now escaping my mind. It's a health equity, I think it's called Finding Answers, Disparities Research for Change. That's a good model program for how one might structure sort of a research portfolio that's specifically centered around health equity. I'm not sure if that's exactly answers your question.
And mental health, I think it was also.
Yeah, that was the
What do you
question, was
think
kind of tying the
funding
mental
Okay.
health to the
Yeah.
access problem.
We've been seeing a lot this past year and a half where monies have been put forth for telehealth, particularly when people can't come in, that there has been a lot more telehealth providers. And providing that care, it doesn't help in rural areas where you don't have, the internet as much. But it has helped people not have to, if they don't have transportation to get in, telehealth has been a great way for folks to receive that particular care as well. And then community-based palliative care, which is a limited model right now because we don't have a robust payment model, does allow for nurse practitioners who are in that mental health space to be able to go into homes.
It definitely sounds as if there's a ripe area for opportunity, because there really isn't so much work in this space.
Yeah, I would agree with that. The last thing I would contribute to that question, it's an amazingly fantastic question, is in palliative care, so anecdotally, in palliative care we talk about this concept of total pain, which is a term that was coined by Cicely Saunders, who's the founder of the modern day hospice movement. It essentially looks at this construct that pain is not just physical, it's made up of components of psychological, social, and spiritual. And certainly, I think in each of our spaces, for those of us who practice clinically, we have seen this phenomenon, particularly over the pandemic, where patients with serious illness have frankly been traumatized through the experience of trying to access care in these very difficult times. And when you certainly think about other issues like racism, how that impacts your ability to access care, it affects your mental well-being. So I think we need funders who are going to look more rigorously at these concepts of total pain and think about what that means for caring for people with serious illness.
Thank you. Next question.
Hi, Michael Tipton, President of the Blue Cross Blue Shield of Louisiana Foundation. Earlier, you all talked about that in this system, we don't have appropriate metrics for health equity or for dealing with palliative care. So in a world where we can sort of rewrite this, what are the right metrics that should be used for measuring ongoing health equity or inequity or relative to palliative care?
Oh, love that question. Who am I going to pick on first?
Inequality.
Yeah, I'm going to pick on myself. Yeah. Yes, I'll put my quality hat on for a second. I mean, I think, so I think we focused so much in metrics on process that we've not focused a lot on outcomes, right? So are these questions being asked, I think is not the right thing to track, but it is what's happening once we ask them. And so things to think through, right, are, you know, if we're going to start screening for social determinants of health, we've talked a lot about how much that impacts care. We should be tracking then who has systems set up or in place where people can then get connected to communities, to organizations, to be able to access the assistance that they need. It's not simply enough to say, I know 10% of my population's food insecure, right? The next step is, okay, what connections do you have with community organizations who can then help that patient get through that? I think those are the kinds of metrics and outcomes that we should be tracking. Yeah, I don't know if anybody has anything.
I love that you mentioned that. There's a program in South Carolina called SC Thrive that actually has a social determinants of health platform to connect providers from across the state around some of those issues and to make those referrals. And then to see how well that person did on the back end. Right. A lot of times with our regular systems, our EMRs are not set up to track everything. And so we do need to have some configuration around our software programs to be able to collect that data. And as a matter of fact, CMS just asked for hospice providers to give them some feedback on measurements because they want to look at this as well. So more to come on this, but right now I know providers don't have platforms set up to capture all of that and to really to make those connections. So that's a great opportunity there to look at how we might be able to do that. And also CMS wanted to know about recruitment of diverse workforce and how well you are doing with that. Where are you going to get that workforce and how well do you engage with your community, you know, and getting at the outcome pieces, so.
Yeah. Thank you. I think there's one more question.
Hi, good evening everyone, and thank you so much for a great panel so far. My name is Ornisha Watson. I'm from the Bristol Myers Squibb Foundation. And one of the things that occurred to me while you were speaking, especially about the advocacy for getting concurrent care at the adult level, was an article that I was reading late last year about, pretty much was a New York Times article called Why Only 28% of Young Black New Yorkers Were Vaccinated. And they were interviewing, you know, respondents from disproportionately affected communities, and some of those were primarily Black. And one of the respondents said, you know, the mayor had I give a little bit more context. He had a program trying to direct the vaccine distribution towards the communities that was hit hardest during the pandemic. And one of the respondents said, when was the last time you ever saw anything that was good for you being directed first towards Black people or towards minority? And so that distrust or, you know, something that was meant to help. Yeah. And I say that to set the stage for even this advocacy for concurrent care. What can we do now to really change the stigma associated with hospice care, especially in communities of color? Because I know the first thing that, you know, family members from my country or my region, the Caribbean, think of when they hear hospice care is, you know, oh, I'm going to die. And now it's like you were saying before, this idea of giving up. So how do we start to change that, you know, that stigma in order to, even if you're successful, to be able to get this type of concurrent care for adults, that they will want it in the minority community?
Yeah, I feel that we have to have an awareness campaign and we have to use people of color who've used the service. I think having those testimonials and those stories are going to be impactful. How we gather all those stories, I think we go to the hospice provider community, and there are those who have provided that care. I was fortunate enough to work for a particular hospice that was owned by an African American, and 95% of our patients were African American. And we worked with African American providers, so I think you have to have providers who have influence in those communities to share their stories. You then have to have patients who are willing to share their stories as well. And then you have to begin to debunk the myths. We have to go through each of those myths. Oh, when you get on hospice, they put you on morphine and you're going to die right away. Oh, when you get on hospice, you have to be able to share with them the truth of those things and why those things occur. And so oftentimes when I'm doing community pieces, I deal with the myths first and then begin to talk about the benefits of the services at the right time. So.
Thank you. With that, it is the top of the hour. Sorry, I know you can catch us afterwards. I want to thank each and every one of you for being here today. I think this was a really great talk. I know I've learned more than I knew when I first walked in here. And if you would allow me, if each of you could just one takeaway, 4 words or less, starting with Nick.
2, 3, 4.
Please add to your portfolio of funding opportunities, funding palliative care research.
All right. I'll let him go. It's a little more than 4 words. Marisette?
That was important for those 3 extra words, right? Me, it would be partnership and collaboration are key. We can do a whole lot when we come together across diverse sectors.
Great. And Kalia, bring us home.
Don't forget children.
Yeah. All right. Thank you.
We're being booted off.
Good evening. What a tremendous day it has been. My name is Osula Rushing. I'm Vice President for Program and Strategy at Grantmakers in Health. Our numbers are climbing, and there are now 639 people registered for this year's conference. We have done amazing things today. We had 3 site visits, 2 focus groups, a meeting of the CEO Working Group on Access and Coverage, the Newcomers Welcome, and 4 workshops. We've heard from our fearless leader, Kara James, and from the incredible Drew Altman, Francis Padilla, Bob Ross, and Kiana Thomason. And then this marvelous panel. Thank you, Nick, Marisette, Kalia, and Cardi. What great insight, what great skill, and what great compassion. Thank you so much for this panel. Many of you have already begun using the hashtag GIHAC on social media. Keep it up. And let me quickly say a bit about tomorrow. The conference agenda is available in 2 formats. So you've got your paper agenda at a glance for dinosaurs like me, and then you have the conference platform, which can be added to a mobile device, and where you can filter sessions by type or by one of our 5 new focus areas. You'll have 5 networking breakfasts to choose from tomorrow morning, all of which begin at 8:30 a.m. And when I say that, I mean that the discussions in the networking breakfast start at 8:30 a.m. Breakfast will be available starting at 8, so there is no excuse to be late, people. Breakfasts, breakouts, and quick take sessions start tomorrow, and there will also be more plenaries, more focus groups, and 2 wellness breaks throughout the day. So I've got 3 tips for you. Number 1. At any given moment tomorrow, you may be forced to choose between 5 to 8 things that are happening at the exact same time. And we have modified our room sets to allow you to have a little bit of physical distance between one another as a COVID-19 precaution. So there will be limited seating in some sessions. If a room is full when you arrive, please select another session. It too will be great. I am confident that having these choices will thrill and delight you, that you will not complain about having to make tough decisions, but will instead join us in a spirit of abundance, celebrating how much we have to talk to one another about over the next 2 days. Tip number 2. To help us track attendance, we'll have people outside of session doors scanning your badges. This information will be used for our internal purposes only. You can think of it as a modern sign-in sheet. If for some reason, any reason at all, you do not want the person who is holding the device to hold it up to you, take off your name badge, hand it to them, they'll scan it, and they'll hand it back to you. Tip number 3. The conference platform includes quick evaluation surveys for each session you attend. To evaluate a session, add it to My Schedule and then click Evaluate Now. Those of you who attend in site visits and workshops can do that actually right now, so I'll just wait. You go ahead. I'm just kidding, but do complete the short evaluations for each session you attend because your wise words make us stronger and better. And now I'm thrilled to introduce Laureen Shant, who's the president and CEO of the Health Foundation of South Florida and one of our conference co-hosts, who is here to welcome us to Miami. Laureen?
Good afternoon, everyone. I recognize that I am standing between you and cocktails, I believe, and I've never been to this conference before, but I'm told that that's an important part of the experience, so I want to be very, very brief. And I want to thank Grant Makers in Health for giving me the opportunity to stand and welcome all of you to what I call my hometown, Miami, in my opinion, the greatest city in the United States. The Health Foundation is really pleased and proud to be one of this year's conference sponsors, and as Osila said, a member of the host committee. And I'm pleased with my staff and I that we had the opportunity to help shape some of what you experienced this morning in your site visits, and I got great feedback. I can tell you we're very proud of the work that's taking place here in Miami. So whether you went to the Underline, or if you went to Miami Gardens to see Live Healthy Miami Gardens, or if you had the opportunity to visit Catalyst and talk about climate, heat, and health equity and resiliency, this is the community for that work. We are groundbreaking in that space. Thank you, GIH, for giving me the opportunity to speak very, very briefly a little bit about the Health Foundation of South Florida, and I will be brief. I know some of you are familiar with our work. We've been a grant maker here in Miami and South Florida for more than 30 years, and we focus on improving health and addressing health equity in South Florida's vulnerable and underserved communities. So through funding, expertise, and leadership, we support work in 3 key areas, like many of you. Improving access and availability to quality health care, the integration of social needs into clinical care settings, and fostering a thriving local economy because, like you, we understand that health is intrinsically tied to wealth, and we're doing some really interesting and innovative things in that space. As part of your conference packet, last week you received an email that linked to the Health Foundation of South Florida's 2021 Impact Report, and I hope you'll take a moment to visit that or to visit our website to learn more about our investments and the team at the Foundation, who many of you know, who has been leading the charge on so many fronts. You'll hear, if you haven't already heard, about the really innovative work led by the Health Foundation of South Florida, the South Florida Anchor Alliance, about our inaugural Black Health Summit, which was held in Miami Gardens last week, and many other innovative and impactful works being undertaken by the Health Foundation. I don't think it would surprise anyone in this room to say that today in Florida, on the heels of a pandemic, and after last week especially, our work has never been more urgent. And to add to that, the fact that we are standing in the least affordable place to live in America, which is a direct result of mass migrations from all across the country down here to Miami. So pair that with all these things and the political environment here in Florida, let's just say so much is changing and not for the better. For sure, I say that because I want to thank GIH for coming to Miami. GIH, thank you for choosing to have this conference here this year, and it's so important because places like Florida, where we as community leaders and the community itself swim in such challenges every day, we need to know that we are not alone. We need your support and your alliance and the spotlight that this kind of a conference brings. Your being here helps us bring attention to our issues and to our battles, to public health, to women's health, to health and racial equity, and to the essential role that philanthropy and advocacy plays in all of it. So I want to thank each and every one of you for being here today and for standing with us. We all have our work cut out for us, that is for sure. I can think of no better place than Miami to find new ways to join forces, to forge new alliances and paths than in Miami, a city where so many come to build new lives and find new ways. It's the perfect backdrop for our collective work and the new chapters we are all writing. So while you are here, I hope you will enjoy this exciting city of Miami, our diverse neighborhoods. I hope you enjoy our culture, our food, our weather, and the vibrancy of this amazing city. So welcome to Miami and enjoy the rest of your conference.